Afternoon, everybody. Thank you so much for joining our early career virtual grand rounds that's sponsored by ATS Critical Care Assembly, most specifically the early career working group. We are very excited to have two outstanding early career investigators talking to us about their research. We have Dr. Monroe from University of Michigan. She's going to talk to us about evidence to implementation evaluating fluid resuscitation in sepsis. And we also have Dr. Khan from Indiana University, and he's going to talk to us about maximizing the cognitive, physical, mental health, and quality of life recovery for survivors of critical illness. Please send your questions in the chat box, but we also will have some time for you to unmute yourself if you prefer at the end of each presentation. So without further ado, Dr. Monroe, the floor is yours.
Great. Thank you so much for this opportunity to be here. I'm excited to share my work talking about fluids in sepsis. So a little bit about myself. I did my early training at University of Chicago, where I did med school residency in a chief year before coming to University of Michigan in 2020, where I did my pulmonary critical care fellowship. My research so far have been on the T32 and then an F32, mainly focusing on vasopressors and peripheral vasopressors. And I'm kind of transitioning into working on early fluid resuscitation and sepsis, which is some of the work I'll share with you today, and relates to my K23, which is awaiting final counsel. So today I'll be talking about two key guidelines in fluid resuscitation and sepsis from the Surviving Sepsis Campaign. That's type of fluid or balanced fluid, as well as the volume of fluid. Specifically, I'll be talking about the 30 milligram per kilogram bolus. And what I like to talk about today is we talk a lot about how evidence leads to the guidelines, but I'm going to focus in on how we're translating those guidelines into practice and what that can tell us about the evidence and how we might be able to improve outcomes for our patients with sepsis. And in particular, I'm going to be talking about HMS. So HMS is a Michigan Hospital Safety Medicine Consortium. It's a quality collaborative initiative sponsored by the Blue Cross Blue Shield of Michigan that has a registry of patients hospitalized with community-acquired sepsis across 69 hospitals all across the state of Michigan. At each site, we have data that's abstracted by professional abstractors. So it's a really robust database that allows us to investigate sepsis-based practices. And in particular today, I'm going to talk about how we've used this database to look at two core questions. How often are patients with sepsis getting guideline-based fluid management? And are the guideline-based fluid practices that we're doing actually associated with improved outcomes? So I'm going to start with fluid type. So the 2021 Surviving Sepsis Campaign guidelines suggest using balanced crystalloids instead of normal saline for resuscitation. Now that evidence is supported for balanced fluid is fairly strong. So we have many trials which on their own have null to slight effects, but in meta-analysis of an RCTs with over 30,000 patients, it does seem that balanced fluid decreases mortality compared to normal saline. And that's particularly true in patients with sepsis where the effect seems to be stronger. So with that background, we asked how many patients are actually receiving balanced fluid in our Michigan hospitals. So in the HMS sepsis registry, this project was looking at 2 years of data, 2021 to 2023, 66 hospitals at that time. And we included patients, these are all patients who have sepsis, but patients who received at least a liter of fluid in 48 hours. So they were admitted to the hospital, they have sepsis, they're getting some fluid. And we looked at how many of those got a majority or more than 75% balanced fluid. And we define that as fluid that was given as a bolus or maintenance fluid being balanced. And what we can see here is that balanced fluid use is actually very low, 12% overall, and very significantly across hospitals. So of those 15,000 patients who have sepsis and got at least 1 liter of fluid during their first 48 hours, depending on which hospital they went to, if you're on a hospital on the left, you may have gotten 50 to 60% of those patients got balanced fluid versus 0% at hospitals on the right. So when we think about what is driving that balanced fluid use, there could be two answers. It could be patient factors or it could be hospital factors. So we performed a multi-level model of odds of receiving balanced fluid. And we saw that patient characteristics, there were a few variables that had small effects. So patients who had malignancy were slightly more likely to get balanced fluid, whereas patients who had kidney disease or had higher predicted mortality were less likely to get balanced fluid. But those patient level effects were dwarfed by the hospital level effect. So the median odds ratio here was 3.87. A median odds ratio is a measure of variation between hospitals. And so a median odds ratio of 1 essentially implies that the odds of getting balanced fluid is the same across all hospitals. So the higher the median odds ratio, and 3.87 is quite high, means that the hospital effect is driving that difference in balanced fluid across hospitals rather than patient characteristics or patient case mix. And that's potentially a problem because not only were balanced fluids potentially beneficial in the trials and meta-analysis that I mentioned, but they also are within our own data. So this is the association of receiving that majority balanced fluid with 30-day mortality. And this top line is the patients, again, this is the population I showed you, any patients with sepsis who got at least a liter, so those 15,000 patients. You can see the mortality if they received a majority balanced fluid was 18% versus 20% if they did not, with an adjusted odds ratio mortality of 0.76. But even more importantly, if you look at those patients who also qualified for the 30 mils per kilogram measure, so those are patients with hypotension or hypoperfusion, they're a little more sick, they're getting more fluid. Those patients, using balanced fluid made a larger difference in mortality, almost 6%, with an adjusted odds ratio of 0.64. So balanced fluids are evidence-based from trials and meta-analysis, but we also see that they reduce mortality in our own population within HMS. But the problem is that this balanced fluid is varying by hospital. So this is a really great opportunity and a key place to pursue quality improvement, which is what we're doing within HMS. So we've created the balanced fluid, majority balanced fluid, turned into a performance measure to encourage hospitals to improve their balanced fluid use. And we've also paired that with educational toolkits and hospital collaboration to help take some information from those hospitals that use a lot of balanced fluid and help see how did they do that, how did they implement that, so that the hospitals that aren't using a lot can take some of those tools and implement it in their own hospital. And we'll be tracking outcomes as we make these changes across our initiative. Now, initial fluid volume is a slightly different story. So the Surviving Sepsis campaign suggests using 30 mils per kilogram initial fluid in the first few hours. The problem here is that there's no randomized control trials of initial fluid volumes because it's kind of hard to catch people this early and enroll them in a clinical trial to say 10 mils per kilogram or 30 mils per kilogram. But with that being said, we do see that over and over again, high quality retrospective studies show decreased mortality with 30 mils per kilogram. And I show here just two examples. These are studies 10 years apart. The one on the left was 9,000 patients in Kaiser. And you can see that mortality on the y-axis, mils per kilogram of initial fluid on the x-axis. And you see this nadir, this U-shaped curve with a decreased mortality around 30 mils per kilogram. Similarly, on the right side, this is a slightly different way to look at this, but they basically took attendings and grouped them by how much fluid they typically gave their patients with sepsis. And again, you see that those attendings that are in that moderate group, about 2.5 to 5 liters, there's this U-shaped curve where those attendings patients had lower mortality. So the problem with 30 mils per kilogram is that there's still some outstanding controversies that have really limited its uptake. So the first, and something I get asked a lot when I talk about fluids, is how should we define this weight-based fluid volume? I had someone tell me I'm not a pediatrician. I don't know how to do weight-based dosing, which I think is very valid and a feeling that a lot of us feel in adult medicine of kind of what weight should we be using, especially in obese patients. And then we also don't really know which patients benefit from 30 mils per kilogram because the guidelines are slightly different in who they target. So we looked at this within HMS, looking at 3 approaches to defining 30 mils per kilogram across 3 patient cohorts. So I'll walk you through each of those before I show you the results. So first of all, we looked at defining 30 mils per kilogram. So how do you determine this weight-based fluid, quote unquote, dose for your patient? And the problem here is that using actual weight doesn't necessarily make sense at extremes of weight. So a 45 kilogram person would get only 1 liter of fluid, whereas a 200 kilogram person would get 6 liters. And an even larger person would get potentially even 7 to 8 liters if you're using actual weight. So what's been done to operationalize this 30 mils per kilogram without using for obese patients this is the approach from step 1. So step 1 is from the Center of Medicare and Medicaid Services. They essentially created this bundle of sepsis care that needs to be implemented, and hospitals actually get reimbursed based on how well they implemented this. And they recognized this problem with actual weight, and they said, well, why don't you use an actual body weight up to a BMI of 30 and then use ideal body weight? So you can see here in this figure that the fluid volume that you would get for 30 mils per kilogram by BMI, and the blue line is the average male height, and the orange line is the average female height. So you can see you use actual body weight and then ideal above a BMI of 30. But the problem here is this leads to an abrupt drop-off in required fluid volume for obese patients that doesn't make a whole lot of physiological sense. So you could say, well, let's take a more pragmatic approach. And this is actually what we had been doing in HMS, where we said, instead of having this abrupt drop off, let's use actual body weight up to a BMI of 30, but then let's just cap the fluid volume at a BMI of 30. So if you had a BMI of 31, 35, 40, you would be getting that same mils per kilo or same total fluid volume as a patient would if they had a BMI of 30, about 2.5 liters for the average male height and about 2 liters for the average female. You could also say, let's take it the opposite way and let's actually make this more tailored. So this is an example of a potential tailored approach where you're using actual body weight for underweight patients, ideal body weight for normal and overweight patients, and then adjusted body weight for obese patients. And this approach has potential advantages because it matches existing studies. There aren't many studies in this area, but what we do know is that using actual body weight is best for underweight patients so that they don't get too much fluid. And again, using adjusted body weight is best for obese patients. So again, so they don't get too much fluid. This approach approximates our renal function calculators as well as pharmacy-based weight-based medication dosing. So it's kind of the same way you would dose a weight-based medication. So these are the three different approaches that we used to defining 30 mils per kilogram in the analysis. We did it, looked at outcomes defining it each of these ways. We also looked at which patients should receive 30 mils per kilogram. So we looked at 3 cohorts based on existing guidelines. So this is within our HMS sepsis registry. For this study, we had 67 hospitals, 2021 to 2024, patients with community onset sepsis. There were 39,000 patients in the overall registry. And we chose our primary cohort to be patients with hypotension or a lactate greater than 4, but we excluded patients who had an EF less than 40%, severe aortic stenosis, or ESRD. And that's because CMS Step 1 bundle says you should be giving fluids to everyone with hypotension or elevated lactate, but they do allow exceptions for patients with heart and renal disease. So we tried to kind of simulate that in this primary cohort, which led us, in that cohort, there's about 11,000 patients or 30% of the total population. The problem here is that there is actually some data that 30 mils per kilogram may actually be beneficial in patients with heart and renal failure. So this is a study from Dr. Liu and colleagues where they had a sepsis bundle that they implemented where 30 mils per kilogram of fluid bolus was a large part of the implementation. And they found that in this top line here, these patients with heart failure or kidney disease at baseline, implementing the bundle decreased mortality by 4%. But it made no difference in patients without a history of heart failure and kidney disease. So this 30 mils per kilogram actually may have the largest benefit in those patients with heart and renal disease. So we have a second cohort, the no exclusions cohort, where we take anyone, all comers with hypotension or lactate above 4. That expands our population by a little bit from 30 to 34%. And again, this kind of fits more with the Surviving Sepsis campaign that says we're going to, suggest 30 mils per kilogram for any patient with hypoperfusion and septic shock. But you can see here that we're using a lactate cutoff of 4 because that's traditionally what has been implemented in step 1. But the question is also, what do you do with those patients with intermediate lactates, 2 to 4? They're not targeted by current guidelines, but that same study that looked at that bundle of 30 mils per kilogram, it actually improved mortality for patients with intermediate lactates. So you see here the years and the bundle compliance in the gray bars. And as the bundle compliance went up, the mortality in that red and then that blue line went down. So maybe these patients with intermediate lactates are people we should be targeting. So we looked at that third population where we expanded it to patients who had hypotension or a lactate over 2. So we have this kind of restrictive primary cohort that really mimics step 1. We have this slightly broader cohort of kind of all comers with hypotension and lactate over 4, and then this even more expanded cohort with patients with intermediate lactates. So then with those 3 approaches and the 3 cohorts across these 9 scenarios, we asked what proportion of patients are actually receiving 30 mils per kilogram within 6 hours? And then what is the association between getting that 30 mils per kilogram and mortality using a multi-level model adjusting for both pre-specified patient factors and hospital level effects? So to walk you through the results, we're going to start with just that primary cohort. So these are those patients who have hypotension, hypoperfusion, no heart failure, no renal disease. And we're looking at these three different approaches: the pragmatic, the step one, and the tailored. So you can see that the highest pass rate, or the most people getting 30 mils per kilogram, was with the step one approach, 58%, although the pass rates are pretty close with all three approaches, being around 50 to 58%. When we look at mortality, you can see that the mortality odds ratio point estimate is lowest for the tailored approach, followed by the step one approach, followed by the pragmatic approach, although the differences are quite small. And again, this is looking between the association of getting 30 mils per kilogram with 30-day mortality. And you can see that getting 30 mils per kilogram decreased mortality regardless of the approach that you were using to define 30 mils per kilogram. So which approach are we using? So honestly, I think any of these approaches are reasonable. They make small differences, but regardless, 30 mils per kilogram does seem to be associated with a reduced mortality in this large cohort. We were using the pragmatic approach in HMS, like I mentioned. We haven't officially decided and finalized things yet, but we are considering moving to a step one approach because it had the highest pass rate, it's simple, and it's already in broad use, and it's associated with the mortality benefit. We were initially concerned about this approach, given this kind of artifactual decrease in fluid volume at a BMI of 30, but that seems to not impact its performance. So then when we think about cohorts, here we are looking at expanding. That top line is what we've been looking at. Now we're looking at that no exclusion cohort with no exceptions for heart and renal disease, and the expanded cohort. And you can see as we expand those cohorts out, that fewer patients are getting 30 mils per kilogram. So in patients with intermediate lactates, that broader cohort, it's only about 35 to 44%. And I don't have it here, but there's wide variation in that across hospitals, as we saw with balanced fluid. But we also see that that getting 30 mils per kilogram is associated with reduced mortality across all cohorts. The raw mortality isn't necessarily reflective of that, but once we adjust for the patient factors, especially in that expanded cohort, we're adjusting for illness severity as well as hospital level effects. You can see that getting 30 mils per kilogram seems to be associated with reduced mortality. So we view this as a potential opportunity to expand the eligible population. Right now, this quality measure is focused on the primary cohort because that is what made sense. Patients who were hypotensive, hypoperfused, but excluding those patients with heart and renal disease that we're often afraid to give fluids to. But perhaps this is an opportunity, and we're going to be discussing this within our group, to expand this measure and target more patients, those patients with intermediate lactates who may also benefit from 30 mils per kilogram. And I wanted to also share this example. So this isn't necessarily, rigorous science, but we do invite our top performing hospital to come talk to us. And so here you can see that we have, this is our standardized mortality ratio. So we took all of our hospitals and we used our predicted mortality score, and we said, what do we expect the mortality to be? And then we looked at actual mortality. You can see this hospital on the far left has a very low standard mortality. Their mortality is about half of what you would expect. And we asked them to come and tell us what they've been doing at their hospital. And one of the biggest things that struck us is that they applied a rapid infusion of 30 mils per kilogram to all patients in the ED with severe sepsis. So even beyond the patients with intermediate lactates, because they were seeing that patients would often come in not as sick, but then would get sicker and get that fluid later. And so they implemented kind of an earlier, broader use of 30 mils per kilogram. And obviously there's other things that can be going on. This is not scientific, but just to kind of speak to the fact that this broad implementation of 30 mils per kilogram may be beneficial. So what we've learned from this study is that 30 mils per kilogram is associated with decreased mortality, regardless of how we define 30 mils per kilogram. And it benefits a larger population than is currently targeting, suggesting an opportunity to improve outcomes. And that's really arguing for a broad application of this 30 mil per kilogram bolus to patients with community-acquired sepsis. Now, I point out that that's community-acquired sepsis because I think this data, while it paints a nice picture, leaves an important knowledge gap that is where my next steps in research is going to focus. And that's on what we do in hospital onset sepsis. So patients who develop sepsis in the hospital rather than presenting with sepsis. Hospital onset sepsis counts for only 1 in 8 sepsis cases, but it carries a really high mortality burden. 1 in 3 sepsis deaths are due to hospital onset sepsis. We also think that patients with hospital onset sepsis have different fluid requirements Patients who are coming in with community-acquired sepsis from home have untreated fluid losses from fevers, diarrhea, et cetera. Whereas patients who develop sepsis in the hospital have a much more complex fluid status. We know they have higher rates of heart, liver, and renal failure at baseline. They're also either already receiving fluids or potentially even already receiving diuretics. So the questions that I am going to be answering in my next stage of research is, what fluid volume should be giving in hospital onset sepsis? Is this 30 mils per kilogram still appropriate? Or is this a situation where personalization may help? So we talk about personalizing fluids to find this optimal fluid volume later. But what I wonder is that in hospital onset sepsis, patients are at a different starting point than community-acquired sepsis. So do we need to use tools and physiology to personalize fluid for these patients? And that's what I'll be answering, or hopefully working on in my K23, which is focused on developing and evaluating a personalized fluid-based approach. It's using a stroke volume guided fluid protocol to address initial fluid resuscitation in patients with hospital onset sepsis during rapid response. I'll be combining implementation science as well as a pilot pragmatic clinical trial to answer some of these questions. So with that, I'd like to say thank you, and thank you to Dr. Prescott, who's my mentor, as well as the rest of the HMS team.
Thank you, Dr. Monroe, for a fantastic presentation. Wondering if anyone in the audience has any questions and would like to unmute themselves or put a question in the chat box. Meanwhile, loved your work. Amazing. William, it looks like you unmuted yourself, so please go ahead.
Yeah, I saw Pat raised his hand too. Hi, Elizabeth. It's nice to see you again, and exciting, exceptional work as always. My question was for a lot of your one question is about the observational analysis and how you handle hospital level effects. Are you putting in, you probably said this, but you put fixed effects in these models to control for hospital level differences in care. So that's my first question. My second question is, it seemed like you were in your K-AIM, you were saying that it's all implementation science. Like, we already know what the right answer is in terms of optimizing fluid resuscitation based on stroke volume. So maybe you could expand a little bit about that too.
Yeah, thank you for those questions. So in all of our models in HMS, we account for hospital effect as a randomized effect. So all the patient level characteristics, which are pre-specified, including our own predictive mortality model that we've developed, are fixed effects, and then we treat hospital as a random effect. And we combine low volume hospitals, less than 10 observations each. But in this data, there's not a lot of those because some of the newer hospitals into our system have few observations, but it's less than 3 at this point. So we're always accounting for hospital effects because we see variation in absolutely everything across our hospitals, because they range from small community to large academic. In terms of yes, so in terms of my K, I do not know that stroke volume resuscitation is going to be the answer. So my goal is to use implementation science. We currently use stroke volume guided fluid resuscitation based on the FRESH trial, which showed that after community-acquired sepsis, after initial fluids, it was helpful in improving outcomes in the ICU. So we've adopted in our ICU, and our goal is to answer, or my goal is to see, does a similar protocol that needs to be adapted because it's not in the ICU, it's out in the world of rapid response on the floor, does a similar protocol help earlier in those patients? Because we find a lot of our patients are coming over to the unit without getting much fluid at all on the floors. Does it help us target fluid? And so the one aim 2 is an implementation aim, but then I will be doing a pilot clinical trial. Obviously, the pilot, so I will have some efficacy and feasibility outcomes. It'll be kind of a mix of both, but I do think that it needs to be validated. I'm not convinced it's going to be the answer.
Can I jump in with one more question?
Yes, please.
That was a great talk. Thank you for sharing it with us. I wonder if you can comment a little bit on diagnostic uncertainty in the moment. It feels like the rapid response situation in particular is often, it's hectic and sort of not clear, who's in charge, much less what's going on with the patient. And so, we give fluid when people are hypotensive much of the time, but I think people are not explicitly saying, let's give 30 cc's per kilogram, unless they're first saying this patient is septic. And so I wonder how you're thinking about that with regard to your project.
Yeah, I think that's a great question. And the way I'm thinking about it is I'm not saying that it has to be sepsis because I think there's too many diagnostic issues with sepsis. It's more of a pragmatic, is this patient hypotensive from a reason you think they're going to respond to fluid? So we're saying, if they're actively hemorrhaging, they're in cardiogenic shock, like, please don't use this. But if you think that they may have a reason to give fluid, let's apply this protocol and see if it helps kind of target that fluid. Because I think that the diagnostic dilemma, I think that leads our hospital has struggled a lot with getting the 30 mils per kilogram and meeting these sepsis measures that we're required to meet from CMS. I think part of the issue is because in these complex floor patients on rapid response or someone develops sepsis in the ICU, it's hard to know when time zero is. It's hard to know when they're septic. So this is much more pragmatic of just, does this help target the fluid to the patient? Because we're sometimes afraid to give it. We're sometimes giving it a bunch and trying to keep them on the floor when we maybe shouldn't be. So it's a much more pragmatic question. And I will be looking at sepsis, adjudicated sepsis, as a secondary and pre-specified secondary analysis. But
Elsie, and I see that you have your camera on. Did you have a question too?
Yeah, I did. I just
Yay.
I'll be very brief because I know we're running into Dr.
good.
Pound's time, but so amazing talk. I'm really interested in your implementation science sort of angle here. And what I thought was particularly inventive is this idea of hospital collaboration and taking high utilizers and trying to sort of collaborate with other hospitals that maybe are not utilizing as much. And so I wonder if you could talk a little bit more about what that looks like. I'm sure every hospital is so different in why they utilize or don't utilize, and like, how are you going to match them? And what is that? Yeah. What do you expect that's going to look like?
yeah, so that's a great question. The beauty of HMS is that it's all baked into our process. So we have collaborative wide meetings 3 times a year where representatives from all the hospitals come together and we pick certain topics. So at the one we had this fall, balanced fluid was one of the topics. And we essentially had tables where people from different hospitals came and sat down and kind of their prompts, but talked about how do you give balanced fluid. A lot of things came up like, we don't only can stock one fluid. So which one should we be stocking? What about, is it okay to just stock LR for all patients? So we have the kind of high performing hospitals come and give presentations, but we then facilitate these kind of small group discussions to help hospitals with, and we do it by based on their systems. So if they use Epic, they're in one room. If they use Cerner, they're in another room. So they can really actually apply what what other hospitals are doing to their practice.
Thank you all so much for your questions. And thank you, Dr. Monroe, for a fantastic presentation. Great work. Dr. Khan, I would like to give you the floor. Thank you for joining us this afternoon.
Thank you very much. And amazing presentation, Dr. Monroe. That was really nice. I am going to share screen here. So thank you very much for the opportunity to speak today. I'm really honored. I am Sikandar Khan. I'm a pulmonary critical care physician by training. And interestingly enough, there's sort of a Michigan connection with what I'm going to speak about today, because Parth Sasani, who was a resident at Indiana University, is now a pulmonary critical care fellow at University of Michigan. So Elizabeth, you might know him. And we published this data together before he moved on to fellowship. So I'm going to kind of dive into that here. I did my residency and my fellowship training at Indiana University, so I've been at this institution for a little bit of time. I don't have any financial conflicts of interest to disclose. My work has been funded through some internal grants, but I'm also very fortunate to be funded by the National Institute on Aging's Paul Beeson Career Development Award, K76. And, I'm going to sort of take us during my talk to what happens after the patient survives sepsis, acute respiratory failure, shock. So I think the timing is really good with Elizabeth going first and me going second, because now I'm really going to take us to how do we continue to provide really good care for these patients long term. So this is a news story that came out about one of our patients who was seen at the Indiana University Critical Care Recovery Center, a post-intensive care syndrome recovery clinic. And in the news article, she had survived ECMO, and this is a quote about her experience and also recollections from her family, that she felt the intubation in her throat, she felt that she was being gagged, and her arms were already so weak while she was in ECMO that she could barely lift them. And I think this is a story that's probably quite familiar to a lot of us on the call, that we see patients in the ICU who start developing ICU-acquired weakness. And then, of course, Yoleti, our patient, was drifting back off to sleep and awakening again, only to forget what the nurse had just told her. So in this little vignette, you can see ICU-acquired weakness, you can see ICU delirium, you can see sleep disturbance that's already happening early in the ICU phase and during acute respiratory failure. And, unfortunately, this, especially coming out of the pandemic, this is not a isolated incident, and there are many risk factors which connect acute respiratory failure and post-intensive care syndrome, or PICS. And the big risk factors include age, comorbidities, frailty, severity of illness, delirium, as well as the duration of mechanical ventilation. And there is some data, some somewhat conflicting data from secondary analyses of prior randomized trials about the effects of neuromuscular blockade, vasopressors, and corticosteroids. But when we actually get to see these patients who survived acute respiratory failure in our clinics, and we're going over all of the different post-intensive care syndrome symptoms, there is a lot for them to sort of reevaluate and reflect on, and for us to measure in an efficient way. And the question is, how should we do this longitudinally in acute respiratory failure survivors? So despite all of our progress in critical care medicine and in mechanical ventilation strategies, up to 75% of acute respiratory failure survivors are still going to develop PICS. So what is PICS, very briefly? PICS has been described since the late 1990s, early 2000s, as a set of symptoms in the patient that include mental health changes, cognitive impairment, as well as physical impairment. And patients can have all of these, or they can have a certain domain of symptoms, which under mental health frequently include depression, anxiety, or PTSD. Cognitive impairment, and can really affect the frontal lobe, the executive function of the patient. And physical impairments include everything from pain, fatigue, to radiculopathy, neuropathy, polyneuropathy. And all of this leads to decreased quality of life. In the focus of my talk today, I'm really not going to talk a lot about the PICS family. I'm going to focus more on the PICS in the patient. But over the past few years, there's been a greater understanding that actually there are even more domains in those classic 3 domains. And patients are experiencing a lot of pain, sleep disturbance, they're having sexual dysfunction, unemployment is at a high rate among these patients, as well as vocal cord dysfunction and other things that are really germane to their quality of life. And a lot of effort has been put into measuring the outcomes in acute respiratory failure survivors. In 2017, there was a Delphi conference that tried to assess a core outcome measure set so that we could really harmonize the evaluation of these patients, both for clinical and for research purposes. And what you'll see is that for many of the functional outcomes, the group could not reach consensus on what are the scales that we should use. And in fact, even for a cognition, they could not reach consensus. And if you think about this from a clinical perspective, if we were to try to measure in clinics or in clinical trials the outcomes in acute respiratory failure survivors, we actually have to piece together multiple different tools and assessment kits to be able to get a global assessment of PICS. So what we did in 2019 is our group validated the HAVC monitor self-report scale. And this is a 27-item scale, as I'm showing on the slide, that has questions that ask the patient to recall difficulty with these symptoms over the past 2 weeks. And there are 3 big domains here. You'll see the cognitive questions, you'll see functional questions, including ones about quality of life, and then the behavioral and mood symptoms. And so we validated this for post-intensive care syndrome, and the total scores in the subscales are shown here with a max possible score of 81. So this is our early work in 2019 to already validate a global PIC scale so that we can actually more efficiently identify, monitor, and follow patients who have PICs or are at risk for PICs. But this leaves a few questions that that I'm going to get to. But in our 2019 validation, we showed that this scale is got good internal consistency and reliability with a Cronenbox alpha of 0.92, and it performed well for its construct validity, especially when it came to the psychological assessments and the mood subscales with good Spearman correlations. So this was our early work in 2019. But as we were caring for more and more patients in both our clinical trials for PICs as well as patients that we are seeing at our survivor centers, some knowledge gaps emerged, which really are, well, what are the psychometric properties of this scale, the HABC monitor self-report? If we are using it over and over again in patients who survived acute respiratory failure to actually monitor the severity of their symptoms and how well does this perform in patients who don't already have the selection bias of being identified as someone who has severe symptoms and has been referred to a specialty clinic. So more closer to the all-comer population of acute respiratory failure survivors. And what's the correlation and the performance of the HABC monitor with certain areas that are not covered currently by the core outcome measure set that I showed you earlier? So specifically, how does the scale perform with correlation for sleep, functional mobility, and pain symptoms? So that's what I'm going to sort of show you the data on today. We performed a secondary analysis of an NHLBI-funded RCT that just recently concluded. That's called the Mobile Critical Care Recovery Program. We enrolled 466 acute respiratory failure ICU survivors in that parent trial from March 2017 to October 2022. The patients in the intervention arm received a 12-month, very intensive multidisciplinary collaborative care intervention that was delivered by a nurse who was visiting the patient at their homes or by phone during the pandemic, versus an attention control where patients received phone calls to ask about their symptoms and were encouraged to follow up with a primary care provider about any symptoms that they were having. But in the intervention group, they got basically a nurse navigator who was helping implement a multidisciplinary care program. The primary outcome was quality of life, and that was assessed by SF36 over 12 months. And the RCT was negative for a significant effect, either on the primary or secondary outcomes. Now, within the intervention arm, the care coordinator used the HABC monitor subscale, self-report, to assess symptoms, but also collected a variety of other process measures to assess cognition, mood, pain, functional mobility, and sleep. So this really set up a nice opportunity for us to look at the relationship between the HABC and these other PICS domains, but also to be able to describe how symptoms are evolving over the first 6 months in acute respiratory failure survivors. So we looked at the internal consistency, the content validity, the sensitivity to change using the ANOVA, and then we also did mixed effects models to look at the change in HABC monitor scores over time and the relationship with changes in the other scales. So I'm going to show you first the demographics of the patients that were included in this secondary analysis. So we're down from 466 patients to 106 patients. That's because we are down to the intervention arm, but within the intervention arm, we're really restricting to patients with whom we have the data that's complete from baseline all the way through 6 months. And so what you'll see is that this was patients with an average age of about 57 years. We had about 40% who identified as Black, About 52% had a high school or less education. The Apache 2 score, the median there is 25, so pretty sick group. And then, the rates of sepsis and shock were about 13%. 66% had ARDS with P to F ratio of less than 200. So again, a severe acute respiratory failure. About 88% were on invasive mechanical ventilation, within 90 median hours of mechanical ventilation for their ICU stay. So a very sick group in the ICU. So this is the psychometric properties of the HABC monitor total score. And what you can see is that the internal consistency was very good with a Cronbach's alpha at baseline of 0.78. And in fact, it got better over the 6 months. So that suggests that using the scale repeatedly, such as has been done in our center and other centers around the world, to follow patients, it does not lose its validity. And in fact, its internal consistency and actually improves. We did see pretty low floor effects. So this is really showing what percentage of patients are at the very minimal symptom set in terms of severity of symptoms for the floor effects. And that's pretty low at baseline. And the ceiling effects definitely are low. So there's not really a lot of patients reporting high symptom severity. And I'll show you that a little bit more in the next few slides. So this is a little bit of a surprise to us. And I think this is really interesting as someone who cares for these patients, both in research trials as well as in the clinics. I'm going to kind of walk you through row by row here. So what you'll see is that the HABC monitor total score was very mild at baseline. So basically, the y-axis is the mean scores on these scales, and on the x-axis, I'm showing you 0, 3, and 6 months time point assessments after index ICU discharge. So their symptoms got markedly better from the 0 to the 3 months, and then sort of plateaued from 3 to 6 months. But there was a significant difference across all three. If you look at the cognitive scores, these are normal scores. These are self-reported normal scores on cognition. And while they were significantly different across the 3 time points, they were very mild at all time points. And similarly with functional self-report scores, their activities of daily living, ability and independence markedly improved from discharge to 3 months, and then started to get a little bit more plateaued out by 6 months. Similarly, mood symptoms improved over time. There was no significant difference. If you look at the hospital anxiety and depression scores, anxiety subscale, this is not significantly different at any of the time points. However, depression did significantly change over time, and you can kind of see that visually, that it was mild to begin with and improved by 6 months. Now, PEG is a pain, enjoyment, and general activity scale. And again, there was mild pain reported at all 3 time points, but you can see a trend line towards improvement by 6 months. Interestingly, also in terms of sleep disturbances, there was mild to moderate sleep disturbance. This is PROMIS sleep short form 4A. And so you can see some improvement over the 6 months. The only scores that actually higher numbers better is on MMSE. And again, these numbers was normal cognition on the MMSE at both time points. So this surprised us in the sense that we expected much more severe PIC symptoms in this cohort, which we didn't quite see. So this is the same data that I just showed you, but now in table format. So I'm just showing you the actual mean and standard deviations, and you can see that these symptoms in every subscale as well as total were mild and improved over time. Now, the next thing that I want to show you is very much a table format of the graphical information I showed you, but really pointing out one item, which is the tug, which I didn't show you in a graphical format. This is a functional mobility, so this is timed up and go. And what this shows you is that these patients were at high risk for falls and continued to be at high risk for falls at all 3 time points, despite aggressive physical rehab and other interventions that they received. And then everything else I kind of talked about through the graphs as well. So the next thing that we looked at is, well, what's the content validity of the HABC? And how does the change in HABC scores over time from baseline to 3 months and then baseline to 6 months correlate with change in the scores and all these other assessments? So change in HABC against change in HADS anxiety or HADS depression, etc. And in bold are all of the correlations that are significant, and the p-values are down here. But what I'd like to really call your attention to is that the psychological subscale in the HABC monitor correlated well with what we would expect with anxiety and depression, but also correlated with the PROMIS sleep score. And actually, its correlation improved from 3 months to 6 months. So it gives us a little bit of assurance that in patients who don't really want to complete a ton of questionnaires in clinic, because we in clinics and in our trials, we do use dedicated sleep questionnaires. If there are patients who don't want to complete everything, if we can at least get the HABC monitor, we might be able to infer some things about whether their sleep is going to be impaired or not, and at least up to baseline to 3 months, give us a little bit of information about pain, but not so much by 6 months. So some of the data that I'm not going to show you in the interest of time today, but is in the full publication, we also looked at the sensitivity to change and how well changes in HABC monitor self-report scores actually were associated with change in the other scales. So from baseline to 3 months, the HABC monitor self-report was sensitive to changes in anxiety scales, depression scales, and pain scales. But baseline to 6 months, it didn't perform as well for anxiety, but it did perform well for depression and for sleep. So, a little bit of a nuance about how this should really be implemented and used in both clinical trials as well as in a global PICS assessment perspective in our clinics. So just to quickly summarize, I want to make sure we leave some time for questions or comments about this. In this cohort of acute respiratory failure ICU survivors, we actually found mild PICS symptoms at all time points. The internal consistency of the scale actually improved over the 6-month follow-up period. And the scale performed well in terms of its correlations with mood, sleep, and physical symptoms, but not with cognitive measures. And as I had mentioned earlier on, there is not a cognitive test that has reached consensus for use in PICS. So really, what we want to emphasize is to use another measure to assess cognition. And I know a lot of centers use MoCA or they might use R-bands. And so those are I think, worth investigating further. The HABC was sensitive to change in mood, pain, and sleep symptoms, but we need longer duration of follow-up as well as looking at the correlation between HABC monitor self-report and other validated assessments that could improve our understanding of the evolution of PICS in this very vulnerable group. I would be remiss if I don't have a lot of folks to thank. This is obviously have to thank our patients who are part of our trials and our outcome studies, but also the division, the NIA, as well as our big research group and the clinics and the survivor centers. So with that, I will pause here and take any questions or comments that you might have.
That was really great. Thanks, Dr. Khan. Alice had to step away to deal with a patient emergency, so she asked if I could moderate the rest of the conversation. I guess maybe I'll kick us off and then see if other folks have questions. You mentioned really briefly a couple slides ago, sort of the progression from using this in kind of a trial setting in patients who are kind of self-selected to eventually making it a bit more, sort of pragmatic and scalable. And I wonder if you could comment a bit more on that.
Yeah, that's a really good question. And actually, part of the nidus for us doing this particular analysis is because we started noticing that the HABC monitor is being rapidly implemented at many centers that are translating it in other countries for their languages and are implementing. And what we are actually doing is we are using a lot of the data sets that we now have, prospective and retrospective, and we are developing another version of the scale to improve upon the areas where the scale may not give us the yield that we're all looking for. So that's definitely next steps, is actually improving upon this and really diving into the item by item response, because there are going to be some items that are stable at every time point, and those may not necessarily be good targets for clinical implementation or research implementation. So we're really trying to dive into which ones have higher variance, which ones are going to change over time, and can we target those and then develop a newer scale that improves the performance compared to this. I hope I answered the question.
You did 100%. You actually pointed out the one thing I was wondering about your answer, which is some of these things are sort of fixed over time and don't seem responsive to intervention. And so why measure? I think that's a really good point.
And Pat, to your point, one of the things that I think we're all struggling with is quality of life. Quality of life is really hard to nudge, but that, of course, we don't want to throw that one out, but how can we actually break it apart a bit more and look at what are the components of quality of life assessments that we might be able to nudge?
Yeah, that's a great comment. Kelsey.
Yeah, I had a quick question. Great talk. An emerging area of research, I think, in the PICS literature is socioeconomic factors that might play a role here, particularly race and ethnicity. With your population, you had quite a diverse population with 40% Black patients and education level less than college degree, both of which I think have been correlated with worse PICS outcomes. So I also was surprised that you didn't see those results. Have you thought about doing a subgroup analysis or looking more at these racial minorities to see if you're seeing more severe PICS outcomes there?
Great point, and absolutely right. And also specifically area deprivation index. There's some literature there as well. And yes, we are. That analysis is ongoing, so we can really try and tease apart all of the because we have all the data. It's just a matter of us actually getting to the analysis and getting it finalized. But yes, it's a big interest area. I think, again, as ICU doctors, though, what do you do with area deprivation? That's gonna, and so fortunately, what's nice about our center is that our health system is very interested in area deprivation. So if we can try and find what is modifiable, they are on a population health trying to go after developing new community programs to directly affect area deprivation, where maybe us ICU doctors can't do it, but the health system can do it.
Sorry, I got kicked out for a second. I caught the end of that, and I think that makes a lot of sense. Other questions folks want to ask? Okay, well, I think we'll wrap up today's session. Thank you both for outstanding talks. This is a lot of fun. I love how kind of intimate and conversational these are. I know folks learned a lot. I got several text messages during this about how much people enjoyed this. So thanks both of you for sharing your awesome work. Looking forward to see where it goes next, and we'll talk to y'all later.
Thanks, bye.